So good afternoon, everybody. And first of all, I would like to thank the organizers for this very kind invitation to have a talk on BPDCN in this really exciting meeting. So just a brief introduction to set the stage. BPDCN is a highly aggressive malignancy derived from the precursors of plasmacytoid dendritic cells. And the exact incidence of this disease is difficult to estimate due to its rarity, evolving terminology, and likely underdiagnosis. However, we have some data coming from US and Europe telling us that an estimated 1,000 to 1,400 cases are annually reported. BPDCN typically involves patients of middle age, and the males are more affected than female. We have also reported cases of pediatric patients. In the last 20 years, the nomenclature and classification of BPDCN changed over time. At the beginning of the century, it was called blastic NK cell lymphoma. Then in 2008, it was considered a subset of AML, and it was defined as a unique myeloid neoplasm in the 2016 WHO classification. And we are quite sure that the frequent reclassification and renaming of this disease has contributed to under-recognition. Today, we have the last version of the WHO classification, 2022, and the plasmacytoid dendritic cell neoplasms is an entity, including two subsets, not only BPDCN, but also mature plasmacytoid dendritic cell proliferation associated with myeloid neoplasm, and the most frequently ones are CMML or MDS. So the message is that we can see PDC proliferations, but it's not always BPDCN. What about clinical presentation? The early recognition of this disease has been challenging because the clinical features of these patients can be really heterogeneous and can overlap other hematological malignancies. That's why there can be a significant delay between the onset of symptoms and diagnosis, and therefore it's very, very important to improve the understanding of the disease and to increase the awareness by clinicians and the pathologists in order to improve our diagnostic timelines. What about clinical presentation? So more than 80% of patients are diagnosed presenting with the skin lesions. You can see here some pictures. These lesions may appear to be indolent at the beginning, but the progression occurs always with involvement of other sites, including bone marrow, peripheral blood, liver, spleen, and in some cases, unfortunately, also CNS. Other pictures here, cutaneous lesions can be different from a patient to another one in terms of size, shape, color, and distribution, and can be confused with other malignant skin lesions or also with other non-malignant skin lesions. They can occur anywhere in every part of our body. What about the path to diagnosis? What happens to our patients? The most frequent scenario is represented in this cartoon. The patient notices an atypical skin lesion in his body. Then he refers to his general practitioner or to a dermatologist. And if the dermatologist is skilled and is aware of the disease, he usually should perform a biopsy of the skin in order to understand what's happening. But I mentioned the term expertise. Expertise is very, very important because if the dermatologist waits too much, the point is that the disease in the meantime can progress. And that's why we usually see that the diagnosis is made after at least 6 months in median from the beginning of the onset of the lesion. Often happens also that this kind of lesion is not diagnosed very well because it can be confused with other hematological malignancies such as involvement by lymphomas or acute leukemias or others. A significant percentage of patients initially present with involvement of the bone marrow and lymph nodes, And as I mentioned before, other sites may include the spleen, liver, and CNS. And only in few cases, BPDCN patients may present with bone marrow disease without skin involvement. These are data from a big cohort of patients, about 400 patients recently published. Another scenario may happen when the patient presents not only skin lesions, but also symptoms leukemia-like, so anemia, thrombocytopenia, neutropenia, fever, not responsive to antibacterial therapy. And in these cases, usually the patient refers to an emergency unit or directly to an hematological center. And then blood counts are performed as well as bone marrow biopsy. And again, expertise is required, not only physician's expertise, hematologist expertise, but also and mainly pathologist expertise in order to recognize from a pathological point of view the disease that is occurring in the bone marrow. So it's a multidisciplinary approach when we have to treat a patient with BPDCN, not only for treatment, but from the very beginning. We have the patient in the middle, and around him at least 4 healthcare professionals, such as hematologists, dermatologists, pathologists, and general practitioners. We have all to interact each other because it's very, very important to follow the patient and to make the right diagnosis from the beginning and during his therapeutic path. What about biopsy? Biopsy is performed more often in the skin, but then also in lymph nodes if they are present, and in the bone marrow. In terms of morphology, we can see very heterogeneous pictures, and you can see here some pictures coming from a paper published 4 years ago. We may observe a typical morphology of pathological cells, but also some variants like lymphoid-like, monoblast-like that are reported here. In terms of immunophenotyping and immunohistochemistry, there are at least 4 antigens which are the signature of this disease: CD123, CD4, CD56, and TCL1. This has been published in the last WHO classification, and you can see here that the immunophenotyping diagnostic criteria include the expression of CD123 and 1 other PDC marker, in addition to CD4 and/or CD56. Or we can have the expression of any 3 PDC markers and absent expression of all expected negative markers. But there are open issues. It could seem an easy diagnosis, but it's not true. Why? Because most markers are not exclusive to BPDCN, but we can find out them also in other diseases. And the co-expression of the 5 most common markers occur only in less than 50% of patients with BPDCN. And the other point is that the use in clinical practice of all these antigens is limited, thus leading to delay again in diagnosis. The recommendations which have been published this year by Dr. Livio Pagano mentioned that the collaboration, again, of clinicians and pathologists is essential in the diagnostic process. There is not always equivalence between the phenotypic profile on tissue sections and in peripheral blood, and that the WHO markers should be used at the beginning together with others to exclude the differential diagnosis. What about prognosis? We all know that, unfortunately, BPDCN patients have a dismal outcome with an overall survival of less than 1 year in most patients when treated with conventional therapies, so with standard chemotherapy. We have identified in retrospective studies some factors which can be linked to a bad outcome, such as elderly age, bad ECOG score, a disseminated disease, cytogenetic abnormalities, and some others which can be predictive for a better outcome, such as the expression of CD303 or an isolated skin involvement. However, multi-center studies are needed in order to better define prognostic predictive factors associated with outcome and therapy response. And talking about therapy, I would like to start with the pre-TAG era. Before the approval of tagraxofus, and we will see the data on this excellent drug later on, there were no approved therapies for these patients and no universally accepted standard of care. due to the lack of prospective trials because it's a very rare disease. So patients were treated with high-dose chemotherapy, AML or ALL-like, followed by allogeneic stem cell transplantation for those patients who were fit and young to receive this kind of approach. And which were the results? In terms of achievement of complete remission, you can see here that with an AML and an ALL-like approach, many patients were able to achieve a CR, more than 70%. But unfortunately, the duration of the CR was very, very short, and the long-term overall survival was totally unsatisfactory. That's why new approaches are strongly required. And what we have learned in the last years is that only allogeneic stem cell transplantation can add something in terms of long-term outcome. You can see here from these pictures that only the patients who receive an allogeneic stem cell transplant have a quite long, but again, unsatisfactory overall survival. So after chemotherapy, we were totally unsatisfactory and unsatisfied, and so and it was a great opportunity to have a new drug, which is now approved by FDA, by EMA, and also by our internal regulatory system in my country, and it's also available in many other countries for patients with BPDCN in first line, thanks to the results obtained in a clinical trial that I'm going to show you now. This was the 4010114 phase 1/2 trial, a phase 1/2 trial of TAG monotherapy in untreated and in already treated patients with BPDCN. 47 patients were enrolled and received TAG on days 1 to 5 of each 21-day cycle. The primary endpoint was to assess the CR rate. Secondary endpoints were overall response rate, overall survival, and safety profile. These were the patients' characteristics. 32 patients with a naive BPDCN were enrolled with a median age of 68. Most of these patients had a skin involvement, 97%, and 47% had also bone marrow involvement. And you can see here the excellent results in the first-line setting with an overall response rate of 77% and a median time to CR of 57 days. And the most important point from my point of view is that about 0.5% of these patients were able to proceed to an allogeneic stem cell transplantation. The median overall survival was not reached with a median follow-up of 25 months, and the probability of survival at 2 years was 52%, something totally unexpected if we consider what we usually saw with the standard chemotherapy. What about toxicity? Which adverse events may occur when we use TAG and when? We can see here in this cartoon that the most important ones are represented by CLS, so capillary leak syndrome, hypoalbuminemia, and the liver toxicity. But if they happen at the beginning in the course 1. So we know that. We don't have to be afraid because we know also how to manage and to prevent, in particular, CLS. In the following courses, the drug is very, very well tolerated. And these are the guidelines that may help us in order to prevent and manage CLS. It's important and recommended to implement albumin during all the courses, in particular during course 1. And here there are all the suggestions regarding what we have to do in the case of CLS occur. What about long-term follow-up? It has been published last year by the group of Naveen Pemaraju. You can see here that, again, the median duration of CR and CRC was 24.9 months, and with a median follow-up of 34 months, the median overall survival was more than 1 year. The importance of allogeneic stem cell transplantation has been confirmed also with this drug. Those patients who achieve a CR with TAG and then are bridged to an allogeneic stem cell transplantation have the better outcome compared to those who don't. And you can see from this cartoon that the median overall survival was 38 months for those patients who, after CR, go to a non-allogenic transplant. But the efficacy of the drug has been demonstrated not only in the setting of first line, but also in relapsed refractory patients. This is a very bad patient population, of course. And again, from the same trial, you can see in this setting an overall response rate of 58%, with a median time to response of 1 month, 29 days, and the median overall survival of 8.2 months, with a median follow-up of about 3 years. So very, very promising data also in this setting. And I want to share with you also the experience of the expanded access program, which has been performed in Europe in the setting of first line. Again, you can see the importance of transplant as consolidation after TAG. The overall response rate of these patients treated with TAG was excellent, 88%, with a CR rate of 71%, and about 50% of the patients were able to be transplanted, with a median overall survival of about 17 months for those patients who received an allogeneic stem cell transplantation. In terms of toxicity, the majority of CLS events were mild, grade 2, grade 3, and no grade 5 events were reported. So it means that we are learning how to manage and how to prevent this kind of adverse events. And this is very important because we are now more confident in the use of the drug and in the treatment of our patients. So these are the last NCCN guidelines, and you can see here that for BPDCN, in terms of treatment induction, TAG is the preferred option, and we have to take in mind that we have to consider transplant for those patients who achieve a complete remission after tagraxofusp. However, there are other options like chemotherapy and low-dose chemotherapy, in particular for those patients who are not candidate for an allogeneic stem cell transplantation. In terms of recommendation, again, the paper by Livio Pagano, which has been published this year, remarks again two mainstays, in particular that the role of transplant is mandatory for those patients who are young and fit in first CR, and that a CNS-directed therapy should be given to all patients. Regarding this topic, I want to show you this paper published again this year by Livio Pagano. This is a review showing that the incidence of CNS involvement in BPDCN may be quite high, not only at diagnosis, but also at relapse. That's why intrathecal prophylaxis and therapy is mandatory for all the patients we have to treat. What about future? We are very happy for the results we have achieved with the TAG, but of course there is room for improvement. That's why there are ongoing clinical trials combining TAG with other agents, doublets with hypomethylating agents, triplet combinations with the venetoclax and chemotherapy, and we will be happy to see these results in the near future. Regarding TAG in monotherapy, we should avoid it only in those cases in which we see that the patients has unmodifiable comorbidities such as low cardiac ejection fraction or others which totally contraindicate the use of the drug. But it's not so frequently observed a situation like this. In all the other cases, we have to follow the recommendations regarding the management and the preventions of CLS and going on using the compound. So take-home messages, an early and accurate diagnosis is essential. Any delays in the time before BPDCN is recognized can mean that disease progression may have already occurred, and this is a problem. Diagnosis requires a multidisciplinary team. It's important that pathologist is skilled in recognizing this disease and in using the right antigens to make the right diagnosis. At this time, we know that CD123 is highly expressed in most cases of BPDCN, and so this is the most appropriate target for therapy, and tagraxofusp is the most important drug in this moment. It's approved by many countries, and it's the best option to induce a complete remission. What's next? We have a lot of work to do, of course. We need to improve expertise in treating these patients. We need to create multidisciplinary teams in the field. We have to identify patients quickly in order not to waste time. And we should be able, I hope in the near future, to allow more and more patients to receive a target treatment such as TAG and to improve the outcome. Finally, I just want to share with you our experience in Bologna with TAG. So far, we have treated 6 patients with this compound, 3 patients in first line, and the other had already received previous treatments before. In the red box, you can see the patients who have received TAG and then proceeded to an allogeneic stem cell transplantation. They were 2 young patients. They are still alive at 35 and 29 months from transplant, respectively, so a great success. But I want to show with you also another case, which is ongoing now. This is a 91-year-old man, so very elderly patient, but in very good clinical condition, who presented in July in our institution due to the presence of a left leg skin lesion, which was detected the first time in January, so about 7 months later. The patient was in excellent conditions, no splenomegaly, no hepatomegaly, no further skin lesions, normal peripheral counts, the heart function was in range. We performed the staging of the disease, and the PET-CT didn't show other glucose hyperuptake except for the skin lesion in the leg. CNS was not involved, and a low amount of MRD positivity was detected in the bone marrow. We decided to start with the TAG at the standard dosage, and we treated the patient with the first course, which started in the middle of August. The drug was very well tolerated. Albumin was given as a supportive treatment every day. In terms of adverse events, we only observed a mild legs fluid retention, which was totally resolved with diuretics, and an hematological toxicity in terms of reduction of platelets count. No other complications. So at the beginning, to be honest, we were a little bit afraid because he is a very elderly patient, but no problems at all. And this is just a picture to show you how the lesion changed only after 1 dose of the drug. This was before TAG, and this is before the second day, so cycle 1, day 2. And you can see that the lesion was really, really different, and it totally disappeared at the end of the 5 days infusion. The patient will start course 2 as soon as peripheral counts will be recovered, and we will move on. Of course, he can't be transplanted because he is 91, and so we will go on with this treatment until progression or relapse. Finally, I want to thank all my coworkers in Bologna, and I will be happy to take any questions.